Today's episode of this FHIR TL video series provides a summary of a FHIR DevDays talk by Thompson. Now, he works at Epic, and Epic has around 10,000 FHIR interfaces, and their APIs were called 74 billion times last year. It would kind of seem that they have ample experience with implementing FHIR at scale. So Cooper discusses the topic of deploying FHIR at scale, and he also gives us some recommendations. Let's hear it from Cooper.
So I guess first there are several dimensions of FHIR scale, and I'll touch on a few, but I kind of had to pick some of my favorites to talk about. And I've been pulled into probably like hundreds of FHIR integration projects over the years. A lot of folks kind of think of things with this model. So I have like a few example USCDI data classes, and a lot of folks are like, oh, EHRs are deployed like this, right? They have Epic is the EHR, we have scheduling, registration, outpatient, inpatient, lab, billing, all of those are done in Epic. So when you're querying for USCDI data, for example, or AUCDI or MedMy content or whatever, you'll get that in the FHIR API. And this is a pretty common deployment pattern where you can expect to get most USCDI from the FHIR data, from the FHIR API, but it's not really the only pattern. So here's a different pattern that does exist, which is that some health systems may choose to use a different system for registration or scheduling or lab. And what this means is that if you're hitting like the EHR's FHIR endpoint, that FHIR endpoint may not have access to coverage data because the coverage, the health insurance information is stored in a different system. Or maybe even worse, if you're expecting the coverage information to be there, is the EHRs may have some subset of that insurance information. Like we may pull in some insurance from the registration system so that when we send a lab order to some reference lab, we can include the coverage for that, but we may not have the full picture. So I wanted to kind of describe this situation so that folks are aware of the different ways that health systems, different ways health systems can choose to deploy their health IT ecosystem and how that can impact the content that you'll get in FHIR APIs. I wanted to kind of talk about some of the diversity we see in the FHIR specification landscape, because when you say FHIR family of products, that's really like a pretty big family of things. So spec diversity in FHIR is something that I kind of first encountered when Argonaut did a survey during COVID for scheduling. So we we wanted to get patients in to get their COVID vaccine, and we wanted to figure out what EHRs had in terms of capability for scheduling vaccine appointments. And so we asked a bunch of EHRs, and all the EHRs came back and said, here's what we support. And many EHRs actually supported a way to do this for FHIR, but they all did it differently. So for example, Epic, we support the Argonaut dollar fine, dollar book operation. So dollar fine to get availability, dollar book to schedule the appointment. Other EHRs were doing a slot search to get availability, an appointment create to book it, or an appointment search for proposed appointments, and then you just update that appointment to book it. And then since then, we've seen even more options where you can do a slot search to find availability and then a FHIR message to actually book it. We see the same thing in referrals where some folks are using like a REST push, like STU3 procedure request.update to submit a referral to a system. Some use messaging and subscriptions, or REST plus messaging, or a task notification, or REST callback. Even in the patient experience, in patient access space, we see variations. So in the US, we're used to like US Core plus Smart on FHIR. But in the Netherlands, they have this MedMy program, which has a separate set of profiles with a JOT claim-based approach using DHID, which is their national kind of authentication solution. And then other countries use like a method of like pushing FHIR data from EHRs into a central HIE that has a patient portal that patients can use. So even in the patient access space, there's variability. E-prescribing, there's at least 3 different things I'm aware of that are doing trying to use FHIR for e-prescribing, and they're very different approaches. So I think like in terms of FHIR divergence, like in the past we've talked a lot about apps struggling with variation of how servers implemented FHIR, and I think like as a server we're also kind of starting to struggle with the variance that we see across IGs. So one of the things that we're kind of focused on to help mitigate that are international realm IGs like IPS and IPA. So IPS is International Patient Summary, IPA is International Patient Access. So with solutions like these, even if the different countries have, or even different realms within a single country have different solutions that are slight variations of this, having a single pattern for a given use case is really helpful for us to scale across different jurisdictions or different agencies within even a single jurisdiction. FHIR is an open spec, so the diversity is a result of just human creativity having access to this spec. But I think there are like significant benefits to like having at least a target folks can shoot for. So IPS and IPA are good targets. So finding other areas where we can at least have a single pattern, even if profiles are different by a little bit, but like the exchange model variation is actually like almost more painful than the profile variation. So IPS and IPA, like they established, here's the exchange model for this type of use case. So more of things like that would be helpful.
Now, I've been involved in the past in transformations of version 2 messages to REST. And the actual data mapping, although not trivial and not painless, but it's certainly doable. But if you try to bridge the exchange mechanism from messaging to REST, that's actually where the pain is. It's just plain hard to somehow transition between operations, messaging, documents, and RESTful exchanges. It's not as seamless as we would all hope. So having predefined patterns will certainly be of help. As a FHIR educator, I'm pleased to offer you best practices and interesting viewpoints in this video series. Please visit our blog for additional TLDW videos.